Okay, this is The Birth of the Clinic by Michel Foucault, chapter 1, called Spaces and Classes. For us, the human body defines by natural right the space of origin and of distribution of disease, a space whose lines, volumes, surfaces, and roots are laid down in accordance with a now familiar geometry by the anatomical atlas. But this order of the solid, visible body is only one way. In all likelihood, neither the first nor the most fundamental, in which one spatializes disease. There have been and will be other distributions of illness. When will we be able to define the structures that determine in the secret volume of the body the course of allergic reactions? Has anyone ever drawn up the specific geometry of a virus diffusion in the thin layer of a segment of tissue? Is the law governing the spatialization of these phenomena to be found in a Euclidean anatomy? After all, one only has to remember that the old theory of sympathies spoke a vocabulary of correspondences, vicinities, and homologies, terms for which the perceived space of anatomy hardly offers a coherent lexicon. Every great thought in the field of pathology lays down a configuration for disease whose spatial requisites are not necessarily those of classical geometry. The exact superposition of the body of the disease and the body of the sick man is no more than a historical temporary datum. Their encounter is self-evident only for us, or rather, we are only just beginning to detach ourselves from it. The space of configuration of the disease and the space of localization of the illness in the body have been superimposed in medical experience for only a relatively short period of time. The period that coincides with 19th century medicine and the privileges accorded to pathological anatomy. This is the period that marks the suzerainty of the gaze, since in the same perceptual field, following the same continuities or the same breaks, experience reads at a glance the visible lesions of the organism and the coherence of pathological forms. The illness is articulated exactly on the body, and its logical distribution is carried out at once in terms of anatomical masses. The glance has simply to exercise its right of origin over truth. But how did this supposedly natural, immemorial right come about? How was this locus in which disease indicated its presence able to determine in so sovereign a way the figure that groups its elements together? Paradoxically, never was the space of configuration of disease more free, more independent of its space of localization than in classificatory medicine. That is to say, in that form of medical thought that historically just preceded the anatomo-clinical method and made it structurally possible. Never treat a disease without first being sure of its species, said Gilibert from the Nosologie of Sauvage, 1761, to the Nosographie of Pinel, 1798. The classificatory rule dominates medical theory and practice. It appears as the immanent logic of morbid forms, the principle of their decipherment, and the semantic rule of their definition. Pay no heed to those envious men who would cast the shadow of contempt over the writings of the celebrated Sauvage. Remember that all the doctors who have ever lived, he is perhaps the only one to have subjected all our dogmas to the infallible rules of healthy logic. Observe with what care he defines his words, with what scrupulousness he circumscribes the definitions of each malady. Before it is removed from the density of the body, disease is given an organization, hierarchized into families, genera, and species. Apparently, this is no more than a picture that helps us to learn and to remember the proliferating domain of the diseases. But at a deeper level than this spatial metaphor, and in order to make it possible, classificatory medicine presupposes a certain configuration of disease. It has never been formulated for itself, but one can define its essential requisites after the event. Just as the genealogical tree at a lower level than the comparison that it involves and all its imaginary themes presupposes a space in which kinship is formalizable. The nosological picture involves a figure of the diseases that is neither the chain of causes and effects, nor the chronological series of events, nor its visible trajectory in the human body. This organization treats localization in the organism as a subsidiary problem, but defines a fundamental system of relations involving envelopments, subordinations, divisions, resemblances. This space involves a vertical in which the implications are drawn up. Fever, a successive struggle between cold and heat, may occur in a single episode or in several. These may follow without interruption or after an interval. This respite may not exceed 12 hours, attain a whole day, last 2 whole days, or have a poorly defined rhythm. Number 2, and a horizontal in which the homologies are transferred in the 2 great subdivisions of the spasms are to be found. In perfect symmetry, the partial tonics, the general tonics, the partial clonics, and the general clonics. 3, or again, in the order of the discharges, what catarrh is to the throat, dysentery is to the intestines. Number 4, a deep space, anterior to all perceptions, and governing them from afar. It is on the basis of this space, the lines that it intersects, the masses that it distributes or hierarchizes, that disease emerging beneath our gaze becomes embodied in a living organism. What are the principles of this primary configuration of disease? Number 1, the doctors of the 18th century identified it with historical as opposed to philosophical knowledge. Knowledge is historical that circumscribes pleurisy by its 4 phenomena: fever, difficulty in breathing, coughing, and pains in the side. Knowledge would be philosophical that called into question the origin, the principle, the causes of the disease: cold, serous discharge, inflammation of the pleura. The distinction between the historical and the philosophical is not the distinction between cause and effect. Cullen based his classificatory system on the attribution of related causes, nor is the distinction between principle and consequences, since Sydenham thought he was engaged in historical research when studying the way in which nature produces and sustains the different forms of diseases, nor is it exactly the difference between the visible and the hidden or conjectural. For one sometimes has to track down a history that is enclosed upon itself and develops invisibly, like hectic fever in certain phthisics. Reefs caught underwater. The historical embraces whatever de facto or de jure, sooner or later, directly or indirectly, may be offered to the gaze. A cause that can be seen, a symptom that is gradually discovered, a principle that can be deciphered from its root, do not belong to the order of philosophical knowledge, but to a very simple knowledge, which must precede all others, and which situates the original form of medical experience. It is a question of defining a sort of fundamental area in which perspectives are leveled off and in which shifts of level are aligned. An effect has the same status as its cause. The antecedent coincides with what follows it. In this homogeneous space, series are broken down and time abolished. A local inflammation is merely the ideal juxtaposition of its historical elements: redness, tumor, heat, pain, without their network of reciprocal determinations or their temporal intersection being involved. Disease is perceived fundamentally in a space of projection without depth, of coincidence without development. There is only one plane and one moment. The form in which truth is originally shown is the surface in which relief is both manifested and abolished. The portrait. He who writes the history of diseases must observe attentively the clear and natural phenomena of diseases, however uninteresting they may seem. In this he must imitate the painters who, when they paint a portrait, are careful to mark the smallest signs and natural things that are to be found on the face of the person they are painting. The first structure provided by classificatory medicine is the flat surface of perpetual simultaneity, table and picture. Number 2, it is a space in which analogies define essences. The pictures resemble things, but they also resemble one another. The distance that separates one disease from another can be measured only by the degree of their resemblance, without reference to the logico-temporal divergence of genealogy. The disappearance of voluntary movements and reduced activity in the internal or external sense organs form the general outline that emerges beneath such particular forms as apoplexy, syncope, or paralysis. Within this great kinship, minor divergences are established. Apoplexy robs one of the use of all the senses and of all voluntary motility, but it spares the breathing and the functioning of the heart. Paralysis affects only a locally assignable sector of the nervous system and motility. Like apoplexy, syncope has a general effect, but is also interrupts respiratory movements. The perspective distribution, which enables us to see in paralysis a symptom, in syncope an episode, and in apoplexy an organic and functional attack, does not exist for the classificatory gaze, which is sensitive only to surface divisions, in which vicinity is not defined by measurable distances, but by formal similarities. When they become dense enough, these similarities cross the threshold of mere kinship and accede to unity of essence. There is no fundamental difference between an apoplexy that suddenly suspends motility and the chronic evolutive forms that gradually invade the whole motor system. In that simultaneous space in which forms distributed by time come together and are superimposed, kinship folds back into identity. In a flat, homogeneous, non-measurable world, there is essential disease where there is a plethora of similarities. The number 3, the form of the similarity uncovers the rational order of the diseases. When one perceives a resemblance, one does not simply lay down a system of convenient relative mappings. One begins to read off the intelligible ordering of the diseases. The veil is lifted from the principle of their creation. This is the general order of nature. As in the case of plants or animals, the action of disease is fundamentally specific. The Supreme Being is not subjected to less certain laws in producing diseases or in maturing morbific humors than in growing plants and animals. He who observes attentively the order, the time, the hour at which the attack of court fever begins, the phenomena of shivering, of heat, in a word, all the symptoms proper to it, will have as many reasons to believe that this disease is a species as he has to believe that a plant constitutes a species because it grows, flowers, and dies always in the same way. This botanical model has a double importance for medical thought. First, it made it possible to turn the principle of the analogy of forms into the law of the production of essences. And secondly, it allowed the perceptual attention of the doctor, which here and there discovers and relates, to communicate with the ontological order, which organizes from the inside prior to all manifestation, the world of disease. The order of disease is simply a carbon copy of the world of life. The same structures govern each, the same forms of division, the same ordering. The rationality of life is identical with the rationality of that which threatens it. Their relationship is not one of nature and counter nature, but in a natural order common to both. They fit into one another, one superimposed upon the other. In disease, one recognizes life because it is on the law of life that knowledge of the disease is also based. Number 4, we are dealing with species that are both natural and ideal. Natural because it is in them that diseases state their essential truths. Ideal insofar as they are never experienced, unchanged, and undisturbed. The first disturbance is introduced with and by disease itself. To the pure nosological essence, which fixes and exhausts its place in the order of the species without residue, the patient adds, in the form of so many disturbances, his predispositions, his age, his way of life, and a whole series of events that, in relation to the essential nucleus, appear as accidents. In order to know the truth of the pathological fact, the doctor must abstract the patient. He who describes a disease must take care to distinguish the symptoms that necessarily accompany it, and which are proper to it, from those that are only accidental and fortuitous, such as those that depend on the temperament and age of the patient. Paradoxically, in relation to that which he is suffering from, The patient is only an external fact. The medical reading must take him into account only to place him in parentheses. Of course, the doctor must know the internal structure of bodies, but only in order to subtract it and to free to the doctor's gaze the nature and combination of symptoms, crises, and other circumstances that accompany diseases. It is not the pathological that functions in relation to life as a counter nature, but the patient in relation to the disease itself. And not only the patient, the doctor too. His intervention is an act of violence if it is not subjected strictly to the ideal ordering of nosology. The knowledge of diseases is the doctor's compass. The success of the cure depends on an exact knowledge of the disease. The doctor's gaze is directed initially not towards that concrete body, that visible whole, that positive plenitude that faces him, the patient, but towards intervals in nature, lacunae, distances in which there appear, like negatives, the signs that differentiate one disease from another, the true from the false, the legitimate from the bastard, the malign from the benign. It is a grid that catches the real patient and holds back any therapeutic indiscretion. If, for polemical reasons, the remedy is administered too early, it contradicts and blurs the essence of the disease. It prevents the disease from acceding to its true nature, and by making it irregular, makes it unbeatable. In the period of invasion, the doctor must hold his breath, for the beginnings of disease reveal its class, its genus, and its species. When the symptoms increase and become more marked, it is enough to diminish their violence and reduce the pains. When the disease has settled in, one must follow step by step the paths followed by nature, strengthening it if it is too weak, diminishing it if it strives too vigorously to destroy what resists it. In the rational space of disease, doctors and patients do not occupy a place as of right. They are tolerated as disturbances that can hardly be avoided. The paradoxical role of medicine consists, above all, in neutralizing them, in maintaining the maximum difference between them, so that in the void that appears between them, the ideal configuration of the disease becomes a concrete, free form, totalized at last in a motionless, simultaneous picture, lacking both density and secrecy, where recognition opens of itself onto the order of essences. Classificatory thought gives itself an essential space, which it proceeds to efface at each moment. Disease exists only in that space, since that space constitutes it as nature, and yet it always appears rather out of phase in relation to that space, because it is manifested in a real patient, beneath the observing eye of a four-armed doctor. The fine two-dimensional space of the portrait is both the origin and the final result. That which makes possible at the outset a rational, well-founded body of medical knowledge, and that towards which it must constantly proceed through that which conceals it. One of the tasks of medicine, therefore, is to rejoin its own condition, but by a path in which it must efface each of its steps, because it attains its aim in a gradual neutralization of itself. The condition of its truth is the necessity that blurs its outlines. Hence the strange character of the medical gaze. It is caught up in an endless reciprocity. It is directed upon that which is visible in the disease, but on the basis, consequently, of the patient, who hides this visible element even as he shows it. Consequently, in order to know, he must recognize, while already being in possession of the knowledge that will lend support to his recognition. And as it moves forward, this gaze is really retreating, since it reaches the truth of the disease only by allowing it to win the struggle and to fulfill in all its phenomena its true nature. Disease, which can be mapped out on the picture, becomes apparent in the body. There it meets a space with a quite different configuration, the concrete space of perception. Its laws define the visible forms assumed by disease in a sick organism. The way in which disease is distributed in the organism manifests its presence there, progresses by altering solids, movements, or functions, causes lesions that become visible under autopsy, triggers off, at one point or another, the interplay of symptoms, causes reactions, and thus moves towards a fatal and for it favorable outcome. We are dealing here with those complex, derived figures by means of which the essence of the disease, with its structure of a picture, is articulated upon the thick, dense volume of the organism and becomes embodied within it. How can the flat, homogeneous, homological space of classes become visible in a geographical system of masses differentiated by their volume and distance? How can a disease defined by its place in a family be characterized by its seat in an organism? This is the problem that might be called the secondary spatialization of the pathological. For classificatory medicine, presence in an organ is never absolutely necessary to define a disease. This disease may travel from one point of localization to another, reach other bodily surfaces, while remaining identical in nature. The space of the body and the space of the disease possess enough latitude to slide away from one another. The same single spasmodic malady may move from the lower part of the abdomen, where it may cause dyspepsia, visceral congestion, interruption of the menstrual or hemorrhoidal flow, towards the chest, with breathlessness, palpitations, the feeling of a lump in the throat, coughing, and finally reach the head, causing epileptic convulsions, syncopes, or sleepiness. These movements, which are accompanied by symptomatic changes, may occur in time in a single individual. They may also be found by examining a series of individuals with different link points. In its visceral form, spasm is encountered above all in lymphatic subjects, while in its cerebral form, it is encountered more among sanguine temperaments. But in any case, the essential pathological configuration is not altered. The organs are the concrete supports of the disease. They never constitute its indispensable conditions. The system of points that defines the relation of the disease to the organism is neither constant nor necessary. They do not possess a common, previously defined space. In this corporal space in which it circulates freely, disease undergoes metastases and metamorphoses. Nothing confines it to a particular course. A nosebleed may become hemoptosis, spitting of blood, or cerebral hemorrhage. The only thing that must remain is the specific form of blood discharge. This is why the medicine of spaces has, throughout its history, being linked to the doctrine of sympathies, each notion being compelled to reinforce the other for the correct balance of the system. Sympathetic communication through the organism is sometimes carried out by a locally assignable relay. The diaphragm for spasms, the stomach for the discharge of humor. Sometimes by a whole system of diffusion that radiates through the body. The nervous system for pains and convulsions, the vascular system for inflammations. In other cases, by means of a simple functional correspondence, a suppression of the excretions is communicated from the intestines to the kidneys, and from these to the skin. Lastly, by means of an adjustment of the nervous system from one region to another, lumbar pains in the hydrocele, but the anatomical redistribution of the disease, whether through correspondence, diffusion, or relay, does not alter its essential structure. Sympathy operates the interplay between the space of localization and the space of configuration. It defines their reciprocal freedom and the boundaries of that freedom. Or rather, threshold, not boundary. For beyond the sympathetic transference of the structural homology that it authorizes, a relation may be set up between one disease and another that is a relation of causality, but not of kinship. By virtue of its own creative force, one pathological form may engender another that is very far removed in the nosological picture. Hence the complications, hence the mixed forms, hence certain regular, or at least frequent, successions, as that between mania and paralysis. Haslam knew of delirious patients whose speech is disturbed, whose mouths are twisted, whose arms and legs are deprived of voluntary movement, whose memory is weakened, and who, generally speaking, have no awareness of their position. Overlapping of these symptoms or simultaneity of their extreme forms are not enough to constitute a single disease. The distance between verbal excitation and motor paralysis in the table of morbid kinships prevents a chronological proximity from deciding on a unity. Hence, the idea of a causality that moves by virtue of a slight time lag. Sometimes the onset of mania appears first. Sometimes the motor signs introduce the whole set of symptoms. The paralytic affections are a much more frequent cause of madness than is thought, and they are also a very common effect of mania. No sympathetic translation can cross this gap between the species, and the solidarity of the symptoms in the organism are not enough to constitute a unity that clashes with the essences. There is therefore an internosological causality, whose role is the contrary of sympathy. Sympathy preserves the fundamental form by ranging over time and space. Causality dissociates the simultaneities and intersections in order to maintain the essential purities. In this pathology, time plays a limited role. It is admitted that a disease may last and that its various episodes may appear in turn. Ever since Hippocrates, doctors have calculated the critical days of a disease and known the significant values of the arterial pulsations. When the rebounding pulse appears at each 30th pulsation, or thereabouts, the hemorrhage occurs 4 days later, more or less. When it occurs at every 16th pulsation, the hemorrhage will occur in 3 days' time. Lastly, when it recurs every 4th, 3rd, 2nd pulsation, or when it is continual, one must expect the hemorrhage within 24 hours. But this numerically fixed duration is part of the essential structure of disease, just as chronic catarrh becomes, after a period of time, phthisic fever. There is no process of evolution in which duration introduces new events of itself and at its own insistence. Time is integrated as a nosological constant, not as an organic variable. The time of the body does not affect, and still less determines, the time of the disease. What communicates the essential body of the disease to the real body of the patient are not, therefore, the points of localization, nor the effects of duration, but rather the quality. In one of the experiments described before the Prussian Royal Academy in 1764, Michel explains how he observed the alteration in the brain during different diseases. When he carried out an autopsy, he removed from the brain small cubes of equal volume, 6 lines in each direction, in different places in the cerebral mass. He compared these extractions with each other and with similar cubes taken from other corpses. The instrument used for this comparison were weighing scales. In phthisis, a disease involving exhaustion, the specific weight of the brain was found to be relatively lower than in the case of apoplexy, a disease involving discharge. Whereas in the case of a normal subject who had died naturally, the average weight was 1 gram, 5 grams. These weights may vary according to the part of the brain from which the samples have been extracted. In phthisis, it is, above all, the cerebellum that is light. In apoplexy, the central areas are heavy. Between the disease and the organism, then, there are connection points that are situated according to a regional principle. But these are only sectors in which the disease secretes or transposes its specific qualities. The brains of maniacs are light, dry, and friable, because mania is a lively, hot, explosive disease. Those of physics are exhausted and languishing, inert, anemic, because phthisis belongs to the general class of the hemorrhages. The set of qualities characterizing a disease is laid down in an organ, which then serves as a support for the symptoms. The disease and the body communicate only through the non-spatial element of quality. It is understandable, then, that medicine should turn away from what Sauvage called a mathematical form of knowledge. Knowing quantities and being able to measure them, being able, for example, to determine the force and speed of the pulse, the degree of heat, the intensity of pain, the violence of the cough, and other such symptoms. Michel measured not to obtain knowledge of mathematical form, but to gauge the intensity of the pathological quality that constituted the disease. No measurable mechanics of the body can, in its physical or mathematical particularities, account for a pathological phenomenon. Convulsions may be due to a dehydration and contraction of the nervous system. And this is certainly a phenomenon of a mechanical order, but it is a mechanics of interlinked qualities, articulated movements, upheavals that are triggered off in series, not a mechanics of quantifiable segments. It may involve a mechanism, but it cannot belong to the order of mechanics as such. Physicians must confine themselves to knowing the forces of medicines and diseases by means of their operations. They must observe them with care and strive to know their laws, and be tireless in the search for physical causes. A true mathematization of disease would imply a common homogeneous space with organic figures and a nosological ordering. On the contrary, their shift implies a qualitative gaze, in order to grasp the disease. One must look at those parts where there is dryness, ardor, excitation, and where there is humidity, discharge, debility. How can one distinguish beneath the same fever, the same coughing, the same tiredness, pleurisy of the phthisis, if one does not recognize here a dry inflammation of the lungs and there a serous discharge? How can one distinguish, if not by their quality, the convulsions of an epileptic suffering from cerebral inflammation and those of a hypochondriac suffering from congestion of the viscera? A subtle perception of qualities, a perception of the differences between one case and another, a delicate perception of variance, a whole hermeneutics of the pathological fact, based on modulated, colored experience is required. One should measure variations, balances, excesses, and defects. The human body is made up of vessels and fluids. When the vessels and fibers have neither too much nor too little tone, when the fluids have just the right consistency, when they have neither too much nor too little movement, man is in a state of health. If the movement is too strong, the solids harden and the fluids thicken. If it is too weak, the fiber slackens and the blood becomes thinner. And the medical gaze, open to these fine qualities, necessarily becomes attentive to all their modulations. The decipherment of disease in its specific characteristics is based on a subtle form of perception that must take account of each particular equilibrium. But in what does this particularity consist? It is not that of an organism in which pathological process and reactions are linked together in a unique way to form a case. We are dealing rather with qualitative varieties of the illness, to which are added the varieties that may be presented by the temperaments, thus modulating the qualitative varieties in the second stage. What classificatory medicine calls particular histories are the effects of multiplication caused by the qualitative variations owing to the temperaments of the essential qualities that characterize illnesses. The individual patient finds himself at the point at which the result of this multiplication appears. Hence, his paradoxical position. If one wishes to know the illness from which he is suffering, one must subtract the individual with his particular qualities. The author of nature, said Zimmerman, has fixed the course of most diseases through immutable laws that one soon discovers if the course of the disease is not interrupted or disturbed by the patient. At this level, the individual was merely a negative element, the accident of the disease, which, for it and in it, is most alien to its essence. But the individual now reappears as the positive, ineffaceable support of all these qualitative phenomena which articulate upon the organism the fundamental ordering of the disease. It is the local, sensible presence of this order, a segment of enigmatic space that unites the nosological plane of kinships to the anatomic volume of vicinities. The patient is a geometrically impossible spatial synthesis, but for that very reason unique, central, and irreplaceable, an order that has become density in a set of qualifying modulations. And the same Zimmerman, who recognized in the patient only the negative of the disease, is sometimes tempted, contrary to Sydenham's general descriptions, to admit only of particular histories. However simple nature may be as a whole, it is nevertheless varied in its parts. Consequently, we must try to know it both as a whole and in its parts. The medicine of species becomes engaged in a renewed attention to the individual, an ever more impatient attention, ever less able to tolerate the general forms of perception and the hasty inspection of essences. Every morning a certain Esculapius has 50 or 60 patients in his waiting room. He listens to the complaints of each, arranges them into 4 lines, prescribes a bleeding for the first, a purge for the second, a clyster for the third, and a change of air for the fourth. This is not medicine. The same is true of hospital practice, which kills the capacity for observation and stifles the talents of the observer by the sheer number of things to observe. Medical perception must be directed neither to series nor to groups. It must be structured as a look through a magnifying glass which, when applied to different parts of an object, makes one notice other parts that one would not otherwise perceive, thus initiating the endless task of understanding the individual. At this point, one is brought back to the theme of the portrait referred to above, but this time treated in reverse. The patient is the rediscovered portrait of the disease. He is the disease itself, with shadow and relief, modulations, nuances, depth. And when describing the disease, the doctor must strive to restore this living density. One must render the patient's own infirmities, his own pains, his own gestures, his own posture, his own terms, and his own complaints. Through the play of primary spatialization, the medicine of species situated the disease in an area of homologies in which the individual could receive no positive status. In secondary spatialization, on the other hand, it required an acute perception of the individual, freed from collective medical structures, free of any group gaze and of hospital experience itself. Doctor and patient are caught up in an ever greater proximity. Bound together, the doctor by an ever more attentive, more insistent, more penetrating gaze. The patient by all the silent, irreplaceable qualities that in him betray, that is, reveal and conceal the clearly ordered forms of the disease. Between the nosological characters and terminal features to be read on the patient's face, the qualities have roamed freely over the body. The medical gaze need hardly dwell on this body for long, at least in its densities and functioning. Let us call tertiary spatialization all the gestures by which, in a given society, a disease is circumscribed, medically invested, isolated, divided up into closed, privileged regions, or distributed throughout cure centers, arranged in the most favorable way. Tertiary is not intended to imply a derivative, less essential structure than the preceding ones. It brings into play a system of options that reveals the way in which a group, in order to protect itself, practices exclusions, establishes the forms of assistance, and reacts to poverty and to the fear of death. But to a greater extent than the other forms of spatialization, it is the locus of various dialectics, heterogeneous figures, time lags, political struggles, demands and utopias, economic constraints, social confrontations. In it, a whole corpus of medical practices and institutions confronts the primary and secondary spatializations with forms of a social space whose genesis, structure, and laws are of a different nature. And yet, or rather for this very reason, it is the point of origin of the most radical questionings. It so happened that it was on the basis of this tertiary spatialization that the whole of medical experience was overturned and defined for its most concrete perceptions, new dimensions, and a new foundation. In the medicine of species, disease has, as a birthright, forms and seasons that are alien to the space of societies. There is a savage nature of disease that is both its true nature and its most obedient course. Alone, free of intervention, without medical artifice, it reveals the ordered, almost vegetal nervure of its essence. But the more complex the social space in which it is situated becomes, the more denatured it becomes. Before the advent of civilization, people had only the simplest, most necessary diseases. Peasants and workers still remain close to the basic nosological table. The simplicity of their lives allows it to show through in its reasonable order. They have none of those variable, complex, intermingled nervous ills, but down-to-earth apoplexies or uncomplicated attacks of mania. As one improves one's conditions of life, and as the social network tightens its grip around individuals, health seems to diminish by degrees. Diseases become diversified and combine with one another. Their number is already great in the superior order of the bourgeois. It is as great as possible in people of quality. Like civilization, the hospital is an artificial locus in which the transplanted disease runs the risk of losing its essential identity. It comes up against a form of complication that doctors call prison or hospital fever. Muscular asthenia, dry or coated tongue, livid face, sticky skin, diarrhea, pale urine, difficulty in breathing, death on the 8th or 11th day, or on the 13th at the latest. More generally, contact with other diseases in this unkempt garden where the species crossbreed alters the proper nature of the disease and makes it more difficult to decipher. And how in this necessary proximity can one correct the malign effluvium that exudes from the bodies of the sick, from gangrenous limbs, decayed bones, contagious ulcers, and putrid fevers? And in any case, can one efface the unfortunate impression that the sight of these places, which for many are nothing more than temples of death, will have on a sick man or woman, removed from the familiar surroundings of his home and family, this loneliness in a crowd, this despair disturb with the healthy reactions of the organism, the natural course of the disease. It would require a very skillful hospital doctor to avoid the danger of the false experience that seems to result from the artificial diseases to which he devotes himself in hospitals. In fact, no hospital disease is a pure disease. The natural locus of disease is the natural locus of life. The family, gentle, spontaneous care, expressive of love and a common desire for a cure, assists nature in its struggle against the illness and allows the illness itself to attain its own truth. The hospital doctor sees only distorted, altered diseases, a whole teratology of the pathological. The family doctor soon acquires true experience based on the natural phenomena of all species of disease. This family medicine must necessarily be respectful. Observe the sick, assist nature without violating it, and wait, admitting in all modesty that much knowledge is still lacking. Thus, on the subject of the pathology of species, there is a revival of the old dispute between active medicine and expectant medicine. The nosologists of necessity favored the latter, and one of these, Vitet, in a classification containing over 2,000 species and bearing the title Médecin Expectant, invariably prescribes quina to help nature follow its natural course. The medicine of species implies, therefore, a free spatialization for the disease, with no privileged region, no constraint imposed by hospital conditions, a sort of spontaneous division in the setting of its birth and development that must function as the paradoxical and natural locus of its own abolition. At the place in which it appears, it is obliged by the same movement to disappear. It must not be fixed in a medically prepared domain, but be allowed, in the positive sense of the term, to vegetate in its original soil. The family, a social space conceived in its most natural, most primitive, most morally secure form, both enclosed upon itself and entirely transparent, where the illness is left to itself. Now, this structure coincides exactly with the way in which, in political thought, the problem of assistance is reflected. The criticism leveled at hospital foundations was a commonplace of the 18th century economic analysis. The funds on which they are based are, of course, inalienable. They are the perpetual due of the poor. But poverty is not perpetual. Needs change, and assistance must be given to those provinces and towns that need it. To do so would not be to contravene the wishes of the donors, but on the contrary, to give them back their true form. Their principal aim was to serve the public, to relieve the state, without departing from the intention of the founders, and even in conformity with their views, one must regard as a common mass all the funds donated to the hospitals. The single sacrosanct foundation must be dissolved in favor of a generalized system of assistance, of which society is both the sole administrator and the undifferentiated beneficiary. Moreover, it is an error in economics to base assistance on an immobilization of capital, that is to say, on an impoverishment of the nation, which, in turn, brings with it the need for new foundations. Hence, at worst, a stifling of activity. Assistance should be related neither to productive wealth, capital, nor to the wealth produced, profits which are always capitalizable, but to the very principle that produces wealth, work. It is by giving the poor work that one will help the poor without impoverishing the nation. The sick man is no doubt incapable of working, but if he is placed in a hospital, he becomes a double burden for society. The assistance that he is given relates only to himself, and his family is, in turn, left exposed to poverty and disease. The hospital, which creates disease by means of the enclosed pestilential domain that it constitutes, creates further disease in the social space in which it is placed. This separation, intended to protect, communicates disease and multiplies it to infinity. Inversely, if it is left in the free field of its birth and development, it will never be more than itself. As it appeared, so will it be extinguished, and the assistance that is given in the home will make up for the poverty that the disease has caused. The care spontaneously given by family and friends will cost nobody anything, and the financial assistance given to the sick man will be to the advantage of the family. Someone will have to eat the meat from which his broth is made, and in heating his tisane, it costs no more to warm his children as well. The chain of one disease engendering another, and that of the perpetual impoverishment of poverty, is thus broken when one gives up trying to create for the sick a differentiated, distinct space, which results in an ambiguous but clumsy way in both the protection and the preservation of disease. Independently of their justifications, the thought structure of the economists and that of the classificatory doctors coincide in broad terms. The space in which disease is isolated and reaches fulfillment is an absolutely open space, without either division or a privileged fixed figure, reduced solely to the plane of visible manifestations, a homogeneous space in which no intervention is authorized except that of a gaze which is effaced as it alights, and of assistance whose sole value is its transitory compensation. A space with no other morphology than that of the resemblances perceived from one individual to another, and of the treatment administered by private medicine to a private patient. But by being carried to its conclusion in this way, the structure is inverted. Is a medical experience diluted in the free space of a society reduced to the single, nodal, and necessary figure of the family, not bound up with the very structure of society? Does it not involve, because of the special attention that it pays to the individual, a generalized vigilance that by extension applies to the group as a whole? It would be necessary to conceive of a medicine sufficiently bound up with the state for it to be able, with the cooperation of the state, to carry out a constant, general, but differentiated policy of assistance. Medicine becomes a task for the nation. Minaret, in the early days of the French Revolution, dreamt of a system of free medical care administered by doctors who would be paid by the government out of the income from former church property. In this way, a certain supervision would be exercised over the doctors themselves. Abuses would be prevented and quacks forbidden to practice. And by means of an organized, healthy, rational medicine, home care would prevent the patient's becoming a victim of medicine and avoid exposure to contagion of the patient's family. Good medicine would be given status and legal protection by the state, and it would be the task of the state to make sure that a true art of curing does exist. The medicine of individual perception, of family assistance, of home care can be based only on a collectively controlled structure, or on one that is integrated into the social space in its entirety. At this point, a quite new form, virtually unknown in the 18th century, of institutional spatialization of disease makes its appearance. The medicine of spaces disappears. That is the end of chapter 1 of The Birth of the Clinic by Michel Foucault.